it.
Yeah.
Namaskar, sir. It's great to see you. And thank you very much for...
Good. So how?
Pardon?
Hi. So yeah. No. So what's the plan? You are doing this in different zones.
Yeah.
You're doing this. So you have done it in other zones already?
Yes, sir. We have done it at South. We have done Kerala. We have done. In fact, you know, our first program at Radisson Rycheck, you blessed us. And in our diabetes book, you blessed us.
Yeah,
Now this is going forward in a good way.
Yeah, good. So the audience will be from the east, right?
No, sir. We have invited from all across.
Okay.
So you know, they would love to share from different parts.
Okay.
I think Gokul.
In fact, let me brief you. But till time the registration is 1,000
Yes,
plus.
sir.
I can't hear you, Mr. Santosh, very well. That's better.
Your audio is not all right, Santosh.
Is it audible?
Yeah. Maybe you had reduced the volume or something. Yeah. It's audible. Now it's audible.
So now, sir, let me brief you about the registration. Till time, the registration is 1,000 plus, where around 500 doctors have registered from East, out of which 400 plus from this Bengal as well as Orissa as well as Northeast. Few doctors from Bihar and Jharkhand as well as UP. Then, sir, 100 plus doctors have registered from Mumbai. 137 doctors have registered from Maharashtra. 147 doctors have registered from entire Gujarat.
Okay.
Then, sir, coming to down the south, sir, around we have registered around 100 plus doctors from Kerala as well as Tamil Nadu, and some 60 doctors from 60 odd doctors from AP. And coming to the north, sir, around we have got around 200 plus registration. So
good. So let's hope some of them join in because we are having so many of these webinars, and RSSDI itself was a very long. Right now, the RSSDI, in fact, from 5:30, the RSSDI general body meeting is on. So I thought maybe I've promised to Santosh to join here, so I couldn't be there. So I feel these programs need to be shorter now, more and more, because people are also getting back to work. In the initial part of the lockdown, people didn't have anything to do, so all day they could just go into webinars, but now they are doing their work as well.
Yes, sir.
So maybe an hour and a half. I mean, this is 2.5 hours, but I know there are a number of interesting topics, which is good. Let's hope we have a good. So we all the speakers have been instructed about the time limit. So how long?
Yes, sir. 20 minutes.
20 minutes each speaker.
Each speaker.
And for the next one, it's 6+2.
Yes, sir.
I mean, yeah. But is there any discussion time now? You gave me a rundown of how the program will run. So does it have, will there be audience questions?
Yes, sir. It will come through, sir, chat box.
So where is the time to discuss them?
Sir, once all the presentation get over,
yes,
we can take up the questions and we can have it.
We can, but where is the time? Where is the time allotted for discussion? If you go back to what you sent me, you had sent me how it will run.
Yes, sir.
So, Sarangi, it is actually 20 plus 5 minutes. Each,
okay.
That is 5 minutes only we can have, but 1 or 2 important questions of each presentation.
So, but I would suggest Mm. That we have the discussions at the end rather than after each talk, because otherwise we may cross the time limits. But anyway, now get in touch with your speakers, make them attend.
Yes,
So we
sir.
don't have long time. So I'll have a couple of phone calls to make. So
Yes, sir.
I'll mute myself.
Right.
Mr. Sarangi.
Yeah, Mr. Gopal.
I will be there here up to 5:45. Then Shubhashri, she will continue here as a panel. This one. Then I have to go to another meeting also, Chennai. That is
Right,
the
right.
monthly, every month, last
Right,
Sunday.
right. Got it.
Yeah. But once that is over, I'll come back here again.
Right.
I think you will have to get in touch with the speaker.
Yes, sir.
And the audience started coming in.
Yes, sir.
Darshan,
Yes, sir.
what is the queue like?
Sir, start कर दे.
Yeah, you start allowing in the people. No? Sarangi? Sarangi?
Yes, sir. Yes, sir.
The event person will give the entry to the people. No?
Yes, sir. Yes.
What is the status? Can you please tell?
Manas, ଆମର
Good evening, Linakshi, Sambit. Good to see you.
Good evening, sir. Namaste.
Namaste. All back from RSSDI?
Yes, sir.
Yeah.
हेलो सर सेशन स्टार्ट करते हैं
Shall we start?
Yes, sir. We'll start.
Dear doctor, am I audible?
Yes, sir. Very much.
Yes, sir.
It gives me a very great pleasure, a very big pleasure to extend a very hearty welcome to our aligned group of faculty led by Dr. Subankar Chaudhary and all the other faculty members. I'm very happy that we are expanding the reach of this ADF with the efforts of Mr. Nagaraja, Sarangi, and my full team of managers. In fact, I thank the East team to have really started this work of ADF and having the real elite faculty member, Dr. Subankar Chaudhary, sir, who helped us start the academic exercise in micro labs at Radisson Reich, and later on helped us build the diabetes book, and now sir is helping us build this exercise, that is the ADF. So I will welcome each one of you. It's a great pleasure that micro is able to scale up our academic presence. I welcome Nagaraj and then Sarangi to carry forward the whole program. Nagaraj? Nagaraj?
Yeah, good evening, doctors.
Yeah, Sarangi.
So let me take this opportunity to introduce myself. I'm Mr. Santosh Sarangi, working as the Deputy General Manager, and I have been associated with Microlabs for the last 17 years. On behalf of Microlabs, I would like to invite our course director, Professor Dr. Subankar Chaudhary, and all the doctors for today's ADF 2020. ADF is nothing but Academics in Diabetes Forum. Our endeavor is to bring the latest clinical updates and trends in the field of diabetes through our eminent doctors and disseminate the current scientific updates among the healthcare professionals. As a company, we take this privilege to reach out to all our doctors through a virtual scientific program during this challenging pandemic time. We are so delighted to have Professor Dr. Subankar Chaudhary as our course director for this event, and also let me welcome all our speakers for this ADF program. Dr. Nilakshi Deka, Dr. Arundhati Dashgupta, Dr. Sunil Kota, Dr. Sambit Das, Dr. Dani Demeher, Dr. Rana Bhattacharjee, and Dr. Sujay Ghosh. Now let me introduce our course director, Professor Subankar Chaudhary, who doesn't require any introduction, but as a customary, I would like to say a few words about him. Sir is presently working as a professor and head Department of Endocrinology in IPJ MER and SSKM Hospital, Calcutta. Sir is also holding other positions like Editor-in-Chief, Indian Journal of Endocrinology and Metabolism. Sir is also past President of Endocrine Society of India, members of Subject Expert Committee, CDSCO, Government of India. Sir is founder patron in South Asian Federation of Endocrine Societies. Sir is also president of Endocrine Society of Bengal. Sir is having a vast area of interest. Few of them is got microbiome and gestational diabetes mellitus. Sir is also having interest in pathogenesis of grave orbitopathy and biology of fat in different body compartments. Sir is having enormous publication in peer review journals, and Sir is having a credit of around 194 journals publication. With this short introductory, let me hand over the entire session to Sir, Professor Dr. Subhankar Chaudhary.
Thank you very much. I warmly welcome all of you, including our very esteemed faculty members and also those who have logged in from different parts of the country to take part in this interesting scientific session. We have a very exciting faculty and also very interesting topics which range from the liver to the brain to the eye to glucose control to discussing some clinical trial to looking specifically at postprandial glucose control and also trying to compare and contrast two of the newer upcoming commonly used anti-diabetic agents, oral anti-diabetic agents, DPP-4 inhibitors and SGLT2 inhibitors. So let's get ready for an evening full of knowledge and learning, which we hope can help us do better, practice better in our daily clinical life. So to start with, we have, can we take away my introduction? Can we have the first speaker, who is none other than Dr. Nilakshi Teka. She is, right, this is mine. She is an excellent person, and she is a consultant endocrinologist at Apollo Hospital as well as Dispur Polyclinic in Guwahati. She has been a speaker at various national and international fora. She won the A.V. Gandhi Award for Best Thesis Topic in Endocrinology in 2013. She has got numerous publications in national and international journals and textbook chapters. So this evening, she will talk to us about non-alcoholic fatty liver disease. Over to Nilakshi.
Thank you so much for that kind introduction, sir. It's always a pleasure to be in a webinar or conference, scientific conference where you are present. So I shall begin with my slide presentation. I'll share my slides. Is my slides visible?
Absolutely, fine.
Yeah, thank you, sir. Thank you so much. So we take a sneak peek into NAFLD, which is a common and a growing menace in today's time. What is the cause of NAFLD? It's the disruption of lipid metabolic homeostasis. It causes accumulation of fat in the liver. It can lead to non-alcoholic fatty liver or non-alcoholic steatohepatitis, which may result in cirrhosis, portal hypertension, and also hepatocellular carcinoma. It is frequently associated with metabolic syndrome, insulin resistance, type 2 diabetes, obesity, and cardiovascular diseases. It is frequent disease and is present in around 5 to 6% of the general population. It is undiagnosed in majority of the cases and is associated with end-stage liver disease and cardiovascular diseases. So spectrum of liver diseases characterized by NAFLD is a spectrum of liver diseases which is characterized by hepatic steatosis, including non-alcoholic steatohepatitis. So disease progresses through various stages of no fibrosis, F0, F1 fibrosis, F2, F3, and finally F4 fibrosis, which is also marked by cirrhosis. Accumulation of liver fat is also associated with various cardiovascular risk factors. And interestingly, when we look at the comorbidity prevalence in NASH and non-alcoholic fatty liver disease, we see that obesity is a frequent accompaniment in non-alcoholic fatty liver disease. It is present in 51% of patients having NAFLD. NAFLD is also associated with 22% of patients with type 2 diabetes. It is associated with 69% patients with dyslipidemia, 39% with hypertension, and 43% with metabolic syndrome. When we look into the other side, that is NASH and NAFLD prevalence in populations with known comorbidities, we see that NAFLD is present in almost 80 to 90% of patients having obesity, 50%, 30 to 50% of patients having type 2 diabetes, almost 90% of patients having dyslipidemia, 21% of patients having hypertension would also simultaneously harbor NAFLD, and it is present in around 56% of those individuals having metabolic syndrome. So non-alcoholic fatty liver disease is a frequent accompaniment of obesity, type 2 diabetes, dyslipidemia, hypertension, and metabolic syndrome. Non-alcoholic fatty liver disease is frequently deemed to be because of an underlying insulin resistance, which leads to increased peripheral lipolysis, increased delivery of free fatty acids to liver, as a result of which there is increased inflammatory markers like C-reactive protein, increased fibrinogen, plasminogen activator inhibitor 1, lipid peroxidation, decreased HDL, increased LDL, increased plasma glucose, and increased free fatty acid delivery to liver. All these inflammatory markers ultimately lead to an increased risk of type 2 diabetes, NASH, as well as atherosclerosis. So it is this elevation in inflammatory markers which is present in non-alcoholic fatty liver disease, which is responsible for the treatment, where we have certain modalities of treatment which actually targets this oxidative stress or inflammatory markers to decrease NAFLD. Steatosis also increases the risk of cardiovascular disease risk, and so presence of NAFLD should raise our suspicions regarding underlying cardiovascular diseases also. Hepatocellular carcinoma and death from non-alcoholic fatty liver disease is very common. And in fact, there is shortened survival, or the mortality from hepatocellular carcinoma and death from NAFLD in those individuals having hepatocellular carcinoma because of NAFLD per se, rather than hepatitis B or hepatitis C, were found to have a shorter survival time. The 61% of the patients who were diagnosed with NAFLD-related hepatocellular carcinoma, in fact, die within just 1 year of diagnosis, which makes it very, very important in our day-to-day practice, and we need to keep this figure in mind. Even those patients who are pre-cirrhotic NASH are at an increased risk of hepatocellular carcinoma. NASH is frequently undiagnosed because of a lack of awareness, lack of early symptoms, lack of easy diagnostic tool, because liver biopsy holds so many inhibitions or apprehensions, and because of a clear-cut treatment for NAFLD. It's a common cause of chronic liver disease in general population. However, interestingly, it causes severe liver disease only in a small proportion of the affected people. There is no evidence of cost effectiveness to support NAFLD screening in all patients, and hence imbibing a concept of vigilance in populations is most important to pick up those cases where it is most likely to be present in NAFLD. Diagnostic modalities include liver biochemistry, which would reflect a slight elevation in AST, ALT, or GGT. However, most guidelines agree that normal levels of liver enzymes do not exclude a diagnosis of NAFLD, and a patient may have non-alcoholic fatty liver disease in spite of having normal aminotransferases or gamma glutamyl transpeptidase. There are various non-invasive diagnostic imaging methods for NAFLD, and there is no unison or there is gross discordance amongst various guidelines to recommend a particular diagnostic modality for the diagnosis of NAFLD. Ultrasound is widely available and is relatively low cost. However, it cannot grade the fibrosis or diagnose steatohepatitis. It also has a limited use in those individuals having a obesity and BMI of more than 40 and low sensitivity if the liver fat content is less than 30%. Computed tomography is there, but it is unreliable to assess steatohepatitis or fibrosis. What is most important is magnetic resonance spectroscopy, which accurately measures the hepatic fat content but has limited clinical application because of the cost and the time taken to perform the procedure. We have another easy modality of imaging, which is transient elastography, or frequently known as fibroscan, which is good for predicting cirrhosis in lean patients, can be performed easily, and results are obtained quite fast. However, it uses continuous a CAP score, which to grade the fibrosis in non-alcoholic fatty liver disease, but there is no precise cutoff levels for fibrosis stage, and it's difficult to perform in patients with obesity. And it can analyze smaller areas than magnetic resonance elastography. We have magnetic resonance elastography, which is accurate for diagnosis fibrosis, can analyze the entire liver. However, it is not used routinely because of the exorbitant cost and not widely available too. Liver biopsy is the gold standard to diagnose non-alcoholic fatty liver disease, but it involves certain complications like pain, major or minor bleeding, and we also have inter and intra-observer variability of pathologic interpretation. The NASH histologic criteria include hepatocyte ballooning, lobular inflammation, and steatosis. And there are various scoring based upon this histopathological examination, like NAS score, or we have the SAF score, which uses the histopathologic findings of biopsy to score the non-alcoholic fatty liver disease. So, however, confirmatory liver biopsy is not to be performed in every NAFLD patient. Instead, it should be reserved for those patients who have an uncertain diagnosis or there is a suspicion of NAFLD-related advanced liver disease. Coming on to how do we treat NAFLD actually, one of the most important measures to treat NAFLD remains lifestyle modification, which consists of diet, exercise, and weight loss. Indeed, weight loss is a measure which has been reported as a cornerstone element in improving the histology features of non-alcoholic steatohepatitis. Dietary restrictions, which includes 500 to 1,000 kilocalorie deficient diet, weight loss of around 500 grams to 1 kg per week with a 7 to 10% total weight loss, is very effective in improving the liver histology markers. Physical activity like aerobic and resistance training, and a diet which includes low to moderate fat and moderate carbohydrate intake, or a Mediterranean diet, has been advocated as a part of NAFLD treatment. So going on to pharmacological treatment, currently there are no drugs which have been approved for the treatment of NASH by US FDA or by the European medicines agencies. All guidelines acknowledge that any medicines prescribed explicitly for NAFLD should be considered as an off-label treatment, and the decision should be discussed with the patient, carefully balancing the benefits and the safety. The guidelines are also widely discordant about the possibly helpful drugs. To speak on the diabetic drugs which have been helpful in NAFLD, we have one of the most commonly used drugs, metformin, which, however, has limited efficacy in improving the histological features of NAFLD, and hence metformin is not recommended by any of the guidelines to specifically treat NAFLD. It gives us, it's a very reinforcing feeling, or it's a very heartening feeling to actually see the use of pioglitazone in non-alcoholic fatty liver disease, with pioglitazone losing the ground in the treatment of type 2 diabetes because of its risk associated with weight gain or increased chances of heart failure. We see that pioglitazone has a very pivotal role in the treatment of non-alcoholic fatty liver disease. In fact, It is a peroxisome proliferator activator receptor, PPAR gamma agonist, with the only agent which has histologically proven improvement in markers of steatosis, inflammation, and ballooning in patients with NASH and prediabetes or diabetes. The PREVENCE trial gives a huge evidence to pioglitazone treatment in NAFLD. It compared low-dose pioglitazone, that is 30 milligram per day, though we use lower doses nowadays because of the risk associated, like concerns like bladder cancer associated with pioglitazone. So in the PREVENCE trial, 30 milligram of pioglitazone was compared vis-a-vis vitamin E 800 IU per day vis-a-vis placebo for 2 years in patients without overt diabetes. And it was seen that pioglitazone improved all histological features except for fibrosis and achieved resolution of non-alcoholic steatohepatitis more often than placebo. The histological benefit occurred together with improvement in aminotransferases and partial correction of insulin resistance. So we see a very important role of pioglitazone in the treatment of NAFLD. Vitamin E is another antioxidant which has been frequently used in treatment of NAFLD, and in fact, it is the PREVENCE trial itself which showed that vitamin E at a dose of 800 international units per day for a period of 2 years was associated with a decrease in serum aminotransferases and also histological improvement in steatosis and inflammation. However, the long-term safety of vitamin E is still under dispute, and it has been associated with an increased risk of stroke or prostate cancer in patients using a very high dose of vitamin E for a longer duration of time. Newer molecules like glucagon, like peptide 1 or GLP-1 analogs have shown favorable results in treatment of NAFLD, and in fact, liraglutide, in a trial which consisted of 52 patients with biopsy-proven NASH, liraglutide administered once daily for 48 weeks was associated with greater resolution of NASH and less progression of fibrosis. Both AASLD and NICE recommendations state, however, that there is still too few evidence to support the use of GLP-1 analogs to specifically treat liver disease in patients with NAFLD. Now, since we are talking about fatty liver disease, so the question of statins in the use of or in patients of NAFLD comes to our mind. Historically, the use of statins in patients with CLD or chronic liver disease has been considered as potentially harmful because of the risk of hepatotoxicity. However, there are very few important points in this slide which says that a considerable proportion of patients with NAFLD, since they also have severe cardiovascular diseases, so they invariably receive statins because of their multiple cardiovascular risk factors. Consequently, the primary concern of the guidelines is actually the safety of statins in NAFLD rather than benefit of statins in NAFLD. In this regard, a recent review underlined the safety of statin and their efficacy in reducing the associated cardiovascular morbidity in patients with NAFLD, including those with slightly elevated alanine aminotransferases up to 3 times the upper limit of normal. All of the guidelines agree about the safety of prescribing statins or continuing an ongoing statin therapy in patients with NAFLD, even in compensated cirrhosis. However, concerns remain regarding the use of statin in patients with decompensated cirrhosis and acute liver failure, and it is not recommended to use statins in patients with decompensated cirrhosis and acute hepatic failure. We have silymarin, which is a mixture of 6 major flavonolignans, and in a randomized trial, silymarin in a dose of 700 milligram 3 times a day for 48 weeks resulted in significantly higher percentage of fibrosis reduction compared with placebo. Silymarin has been mentioned as a potentially useful treatment for NASH in the Asia Pacific guidelines only. However, the optimal dose and duration still require further studies before a full recommendation. Bariatric surgery is another modality of treatment for non-alcoholic fatty liver disease, which is unresponsive to lifestyle modification, where an individual has not been able to lose weight with lifestyle modification alone. And it has been seen that bariatric surgery can also improve the liver histology regarding steatosis and ballooning. Liver transplantation is becoming one of the most common indications In Western countries, liver transplantation in NASH or non-alcoholic fatty liver disease is becoming a frequent indication for liver transplantation. We have AGLE2 inhibitors, which has been shown to reduce the fatty liver content as assessed by different imaging techniques and improve biological markers of NAFLD. In fact, the beneficial effect of AGLE2 inhibitors in non-alcoholic fatty liver disease is not just related, or it is beyond just reduction in hyperglycemia and body weight, and a potential role for the decrease in low-grade inflammation and oxidative stress associated with AGLE2 inhibitor therapy has been found to be one of the positive effects of AGLE2 inhibitors on NAFLD. And this effect of AGLE2 inhibitor on non-alcoholic fatty liver disease, we know already complements their already well-known effects on cardiovascular and chronic kidney disease. And then we have saroglitazar, which is a combined alpha and gamma PPAR agonist, which has been shown to improve dyslipidemia and non-alcoholic fatty liver disease too. So summarize, we have non-alcoholic fatty liver disease, which is frequently accompanied by type 2 diabetes, obesity, cardiovascular diseases, and metabolic syndrome. Lifestyle intervention and comorbidities treatment remain the cornerstone. We have bariatric surgery and also pharmacotherapy in the form of vitamin E, pioglitazone, AGLE2 inhibitors, GLP-1 receptor agonist, pemafibrate, or we have the apoptosis kinase inhibitors, semaglutide, OCA, etc. And surveillance for hepatocellular carcinoma is important because patients having hepatocellular carcinoma in patients with NAFLD have a shorter survival compared to hepatocellular carcinoma in hepatitis B or hepatitis C. I came across this slide in an article, and it was quite heartening to see the role of multiple specialties as in the treatment of non-alcoholic fatty liver disease. So non-alcoholic fatty liver disease is not just a domain of gastroenterologists now. It includes hepatologist, cardiologist, endocrinologist, dietitian, as well as the patients themselves, because without motivation and proactive role of the patients, which involves their important role in lifestyle modification, it is impossible to achieve any fruitful outcome in non-alcoholic fatty liver disease. With that, I thank you for the patient hearing.
Thank you very much, Nilakshi. That was a beautiful overview of this quite a vast subject today of non-alcoholic fatty liver disease. I just wish to point out that while it goes hand in hand with obesity, there is also a significant subset of NAFLD which happens in people who are non-obese. So, and there maybe the question of weight loss does not come in, but then possibly physical exercise still has its beneficial role. The other issue, of course, is what we do once we diagnose. And of course, you have tried and sort of shared with us whatever evidence we have got at this moment. So for all our, those in the audience, whoever wants or has a question, please communicate, put it in the chat box or whatever. We shall come back to all of you at the end. So we go on to the next topic, which is on diabetic retinopathy. We are in recent times maybe more involved with protection of the heart and the kidney, because we have got drugs which have shown beneficial effects. And it's the pharma industry which raises the pitch, the noise level. So it's very apt that Dr. Arundhati Dasgupta, our next speaker, has chosen the topic of diabetic retinopathy. She is another brilliant endocrinologist, and she's a consultant endocrinologist at the Rudraksh Super Speciality Care in Siliguri. I have been interacting with her over the last several years, and I find her a very efficient endocrinologist, a wonderful speaker. And what in recent times she has been sharing with me the different public awareness programs that she is involved with. And I'm really surprised to see that she has already conducted more than 150 awareness programs on diabetes and lifestyle diseases, not only in Siliguri, but all around in North Bengal, even beyond West Bengal. She's been to Sikkim, to Bihar, to Nepal. So it's wonderful to know that Arundhati is doing so much of work at the grassroots level. So the forum is yours, Arundhati.
Thank you so much, sir, for that kind introduction. That really means a lot to me coming from you. So I think I have to be allowed to screen share. Yeah.
Yeah.
So as Sir just told us that, we are these days concentrating a lot on the cardiovascular aspect, on the other aspects, and even on maybe the kidney aspect, because we are getting drugs which are kind of having some effect on those. But so when I was asked to choose a topic, I chose this topic because I thought that we needed to look at retinopathy from a physician's perspective. It's generally a screening that is done and we see any changes of retinopathy and we refer to a retina specialist. But do we really have anything more to do besides just that, is where I would like to take a look at tonight. So the global prevalence of retinopathy is something like this, to the tune of 35%. Across the spectrum, from proliferative to macular edema and vision-threatening diabetic retinopathy, being between 5 to around 10%. So, and if you look at the data from India, the figures are also not very different, but varying from 10% to around 26% across the different studies that have been conducted. Now, these are comparisons between the vision of a normal person and a person who has diabetic retinopathy. The first being a person who's got gross hemorrhages, and the second being where they're having macular edema and others, and exudates and others, whereby there is blurring of vision. So we'll just look at a patient who comes to us from a physician's perspective. So case number one is a 54-year-old gentleman who's been a diabetic for the last 10 years. He's a smoker. He has a sedentary lifestyle. He has a BMI of 26, a BP of 145/90. Sugar levels are not good. HbA1c is 8.3. LDL is 140. TSH is 8.6. He has a hemoglobin of 10.5 and urinase serum of 206. So firstly, coming to the screening, whom should we as physicians, as endocrinologists, screen for diabetic retinopathy? So when to start? For type 1 DM patients within 5 years after the onset, and for type 2 DM patients at diagnosis, we know that. But if retinopathy is present, so we need to diagnose the severity and monitor at appropriate intervals. And if retinopathy is progressing or sight-threatening, then obviously examinations are going to be required more frequently. We need to review the glycemic control, of course, the blood pressure, lipid control, and adjust therapy. And of course, look for the other diabetic complications, because we do know that retinopathy goes hand in hand with nephropathy. And if after the screening you find that the retinopathy is not there, then it is usually advocated to rescreen every 1 to 2 years. So what is the progress? Like if you see a patient who's got like a mild NPDR without any significant macular edema, what are the chances of risk of progression to proliferative retinopathy in 5 years? In 1 year is 5%, in 5 years is 15%. So a person whom you see today with just microaneurysms might go into a proliferative diabetic retinopathy. 5% of them might go into proliferative diabetic retinopathy in 1 year. And so therefore, this chart is very important, because if you're seeing a moderate NPDR, see what are the chances. 33% chance of going into a PDR in 5 years, severe 60% chance. So thereby they need the follow-up much more frequently, 3-monthly or 6-monthly follow-up, and definitely a reference to a retina surgeon. But you also need to reinforce the fact, because they just might go to the retina surgeon and then never visit him again and come back to you after 1 year where things might have progressed. So these things need to be emphasized to the patient. Coming to our patient in question, the first point, he's been a diabetic for the last 10 years. So does duration of diabetes matter? Yes, it does, because let us see what happens in type 1 diabetics. So more than 5 years, chances are low. 5 to 10 years, 27%. 10 to 20 years of diabetes, 71 to 90%. And more than 20 years of diabetes, 95%. In type 2 diabetes, 11 to 13 years, 23%, and going up to 96% for those who've been diabetics for the last 30 years. So definitely when you see a patient for whom the duration of diabetes has been longer, that is an important area, to think that yes, this patient might have retinopathy. So this was a very famous study, the WESDR study, wherein they looked at the prevalence of retinopathy at 3 years, 5 years, 10 years, and 15 years, and they said it was 8, 25, 60, and 80% respectively. And the 4-year incidence of proliferative retinopathy increased from 0 during the first 5 years to 27.9% during years 13, 14. So that's like a real exponential rise in the risk of diabetic retinopathy, which needs to be kept in mind. Very similar data there. The second point that we saw was the BMI, 26.1. So does obesity matter in retinopathy? Yes, again, it does, because these have been found to be the mechanisms, the involvement of platelet function, viscosity, aldose reductase activity, the VEGF factor, increased local adipose and systemic inflammation, causing a release of a large number of cytokines and mediators, namely leptin, adiponectin, tumor necrosis factor, that do influence diabetic retinopathy development. So it's just not about the glycemic control, the control of your patient's weight also would have a role to play in the progress of retinopathy. So the evidence between high BMI and increased risk is inconclusive, though most studies have demonstrated a relationship between the higher BMI and DR. But it is an important modifiable risk factor which could have potential clinical implications in the management of diabetic retinopathy. Next point being the blood pressure, 145/90. So retinopathy and hypertension. If we look at the UKPD's BP arm, where a total of more than 1,000 hypertensive patients was randomized to less tight, which was less than 180/105, and tight, which was less than 150/85, much higher than what we usually keep our patients at, and with the use of ACE inhibitor and beta blockers. So there they showed that there was a 34% reduction in the progress of retinopathy and a 47% reduction in the risk of deterioration of the visual acuity in association with the 10 and 5 systolic and diastolic reduction in blood pressure. But if we look at the ABCD trial, they again said that there was no difference between an intensive group and moderate group, in terms of progress to retinopathy. But here, of course, the intensive group was 132/78 and moderate control group was 138/86. So all in all, we can see that around 140/80/85, this appears to be a good blood pressure control in terms of retinopathy, and anything higher than that tends to make it progress. The EuroDiab study again looked at the role of lisinopril, and they did say that it did reduce the development of retinopathy. But whether it was because of the lisinopril per se or because of the pressure reducing effect was not something that they could firmly comment on. Ultimately, in 2015, we had a Cochrane review which said that the available evidence supports a beneficial effect of intervention to reduce blood pressure with respect to preventing diabetic retinopathy. Blood sugar control, of course, being a major game changer. We have seen it from the DCCT trial. We've seen it from the other trials also. Intensive control does reduce microvascular complications, and retinopathy is also one of the stronger complications that are reduced. We can see the DCCT trial that intensive control brought down the risk of diabetic retinopathy by 76%. The risk of progression of pre-existing retinopathy by 63%, and the need for laser surgery by 56%. UKPD has also told us that a 1% degree in HbA1c decrease brought a 35% decrease in microvascular, but in terms of retinopathy, that translated into a 17% risk in progress, 29% decrease in the need for laser photocoagulation, 23% decrease in the development of vitreous hemorrhage, and 16% in the incidence of legal blindness. So all of these, UKPD's, DCCT, Accord, Advance, have given us kind of good data with intensive control in terms of microvascular risk reduction. Now looking at the statins. So retinopathy and lipids, do they matter? So we do know that the hard exudates do contain the lipid, exudates, which have come out and they appear very whitish in the fundus examination. But increased risk of hard exudates was found to be associated with increased serum cholesterol also, though it was not significant in predicting the severity of retinopathy in the WESDR study. In the early treatment diabetic retinopathy study, they said that there is again a significant correlation between elevated cholesterol, high density lipids, and triglyceride with development of hard exudates. And atorvastatin was shown to decrease macular edema, severity of hard exudates, and subfoveal migration of hard exudates. So these again were having multiple studies which have looked at the lipids. And as you can see, many of them have said non-significant, but some have said that yes, cholesterol levels do matter, and a decrease, as you can see, plus. These are the studies which have said that yes, cholesterol levels do have a role to play in terms of retinopathy. Now, what role do statins have? Cards showed that if you gave atorvastatin daily, that had a reduction in the laser therapy compared to placebo, but no influence on diabetic retinopathy progression per se. But Steno 2 again revealed a significant reduction in the number of patients with progress in retinopathy with intensive therapy with statins and or fibrates. Now, coming to the question of fibrates, there have been studies which have looked at clofibrate and hard exudates, but not significant improvements have been seen with the use of fibrates, though there have been some studies like the field study which they looked at patients treated with fenofibrate, and they did say that such patients were less likely to demonstrate progressive pre-existing retinopathy or to develop macular edema. So this is the field retinopathy. They said a reduction in the need for laser treatment in the fenofibrate group. As you can see there, all these first laser for PDR, all laser for proliferative, all these areas, they showed beneficial effect with the use of fibrates. Again, the Accord Eye study also did say that fenofibrate in the statin combination compared to statin alone offered benefit in terms of delayed progress of diabetic retinopathy. Another point that has been marked out in this patient is a hemoglobin level of 10. Now, generally we wouldn't think much about a hemoglobin level of 10 in terms of retinopathy, but it appears that low hemoglobin has been found to be an independent risk factor for the development of high PDR and severe vision loss because of anemia-induced hypoxia and because of the flexibility of RBCs in diabetic patients being much less compared to normal individuals, and which could be involved in the exacerbation of diabetic microangiopathy. So the point that is being try to be raised here is that it's not only about the glycemic control, it's not only about the lipids, it's not only about the blood pressure, it's also about the BMI, it's also about the hemoglobin, it's also about the TSH. And that brings us to the TSH out here, subclinical hypothyroidism and retinopathy. So the association between subclinical hypothyroidism and retinopathy has been controversial. Some have said yes, some have said no. But what could be the possible mechanisms? Could be because the insulin resistance in subclinical hypothyroidism, the presence of increased CRP, the serum homocysteine level, or the oxidative stress. So whether you're going to treat subclinical hypothyroidism because you want to prevent the progress of retinopathy is again your take. But as I said, there are studies on both. There are studies which say that yes, it gives you benefit, and other again studies which say no. We'll just go on to another aspect, the sedentary lifestyle. So retinopathy and exercise, an important area, because our patients come back to us. You send them to the retina surgeon, they come back to you. Maybe something has been done or maybe not. And then they ask you that, should I limit my physical activity because I've got this problem in my eye? So for mild and non-proliferative, there is no reason to limit physical activity. For moderate or severe, so the activities that cause a rapid change in blood pressure, like exercise that involves rapid change in direction, like court sports, or sudden bursts of movement like golf, like baseball, like martial arts, and very high intensities like sprints, racing, heavy weightlifting, isometrics, or placing the head below the level of the heart as occurs during yoga. These need to be avoided. Moderate intensity cycling, swimming, walking, these are generally acceptable with warm up and cool down periods. Somebody who's had a recent laser eye surgery, retinal hemorrhage or detachment, that in that patient, that category of patients, they can exercise, but it has to be low level and the heart rate should not exceed 30 beats per minute above the resting levels. Remember, our man out here is also a smoker. So retinopathy and smoking, there is a relation, though the evidence is not very strong in nephropathy, but in retinopathy, the association has been strongly established. Eurodiab IDDM demonstrated that smoking is an individual risk factor for the development of the progress of diabetic retinopathy. So, so many areas where we can take action, where we could prevent the progress of retinopathy. And that is what we need to keep in mind, that it's not only about the glycemic control. So, and then there are questions about aspirin. Like, if you have retinopathy, is it all right to use aspirin? So there was a study, the early treatment for diabetic retinopathy study, which showed that the dose of aspirin, even around 650 milligram, did not offer any benefit, but there was no increase in the risk of vitreous hemorrhage also. So somebody who needs it for any other particular reason, you would be giving it, but you wouldn't be giving it per se, to avoid the progress of retinopathy. Just go over to a short case, the case number 2. It's a 33-year-old female who wants to plan pregnancy. She's been a diabetic for the last 3 years, has a BMI of 23, BP of 135/90, sugar levels are not optimum, HbA1c is 7.3, LDL 100. Otherwise, the other reports are normal. So pregnancy, this is an important area because we do know about the risk of progress of development and progress of diabetic retinopathy during pregnancy, and changes occur in 50 to 70% of diabetic women, with the greatest risk of worsening occurring during the second trimester and persisting as long as 12 months postpartum. So the other factors found to be associated with the progress in pregnancy is also the duration, the severity of retinopathy at conception, the glycemic control, anemia, and progression of coexisting hypertension. So that needs to be kept in mind, because these have been the explanation as to why retinopathy progresses during pregnancy. The hormonal changes in terms of increased levels of lactogen, estrogen, and progesterone, the changes in the systemic vasculature because of the hyperdynamic circulatory state during pregnancy, which potentially inflicts additional shear and stress, and the autoregulatory mechanism impaired in diabetic retinopathy. So assessment during pregnancy, following the first antenatal clinical appointment at 28 weeks, if during the first assessment, if there were any changes of diabetic retinopathy, the patient should be seen again around 16 to 20 weeks. With pre-proliferative changes during pregnancy, should have a 6-month follow-up after delivery. And vaginal delivery is not a contraindication in patients with diabetic retinopathy. Intensive therapy during pregnancy, we tend to bring the levels quite low because our targets are very low. That also tends to increase the risk of progression of diabetic retinopathy. And the DIAP study, the women with the greatest reduction in the HbA1c during the first trimester were at an increased risk. So that's a catch-22, because you would want them to have lower levels at the same time. If they have pre-existing retinopathy, that could increase the risk because of various mechanisms, because of decreased plasma volume and closure of the small retinal vessels and others. So in summary, looking at both our cases, the first being a gentleman who's hypertensive, diabetic, dyslipidemic, obese, who's a smoker, who has a sedentary lifestyle, apparent and subclinical hypothyroid, mild anemia. So, apparently that appears like a lot of things which are happening. But when you look at our patient profile, we have a lot of patients who are in that category. So we do need to look at a comprehensive control of so many factors if we really, really want to prevent the progression of microvascular changes, and retinopathy is one which is distinctly affected by so many other factors. Also, for females who are planning conception, we need to understand the significance of what pregnancy can do to the eye, explain it, follow up adequately, and take adequate measures so that the patient does not land up with major eye problems. The summary of this presentation being that the prevention and occurrence and progress of retinopathy involves a complete comprehensive management of the patient and not just glycemic control. And on that note, I'll stop sharing my slide.
Thank you, Arundhati. That was wonderful. Actually, opening up a whole new vista of diabetic retinopathy, and really enlightening each one of us as to the holistic nature you need to look at retinopathy. I'm sure there'll be questions, but for now, we'll go on to the next talk and the next speaker. So we have traveled from Guwahati to Siliguri, and now as Orissa Tourism now promotes see Orissa by road. So we reach Behrampur by road, possibly, and we reach Dr. Sunil Kota, who is another young consultant endocrinologist at Diabetes and Endocare Clinic. He has numerous publications, and I'm very happy that he is one amongst various other accolades. He has one from our own Endocrine Society of India. First of all, the most number of publications in IJEM in 2012, and subsequently in 2018, he was a more mature person now, and so he won the Best Reviewer Award. And then that apart, of course, he has, it's very proud that he won the Best Poster Award at the American Association of Clinical Endocrinology meeting at Philadelphia in 2012, where his paper on ileal transposition, interposition with sleeve gastrectomy for treatment of type 2 diabetes was presented. So over to you, Sunil, and to talk on, again, a topic that is not so often discussed, the brain and diabetes, or diabetes and brain. And you have the very cerebral Sunil Kota to take us through this. Over to you. Sunil, you're finding it difficulty to share your slides, and you may unmute yourself.
Yes, sir. Sunil, sir, you can unmute yourself.
Maybe Sunil has having some connectivity issues. Shall we, Mr. Santosh, will you call him up, and shall we go to Sambit? If Sambit is, no, Sunil, are you ready?
So just allow me a minute of time, sir.
Yeah. Sunil, you are ready, I hope? And Sambit, you are ready. If Sunil cannot, okay, fine, good. So we will allow a couple of maybe 30 seconds more. No, let's not go over to. Did you hear back from Sunil, Mr. Santosh?
Sir, good evening, sir. I have joined back. Is it okay to come in?
Yes. Sure. Please.
So, is it visible to everyone now?
Yes, sir.
No. I mean, your presentation is not visible. Please share screen. Sunil, are you there? So with Sunil's permission, let's go over to Dr. Sambit Das, and then we'll come back to you. So the next speaker for this evening is none other than Professor Sambit Das, who is Professor of Endocrinology at the High Tech Medical College and also Senior Consultant in Endocrinology at the Endeavour Clinic and Apollo Sugar Clinic in Bhubaneswar. So we are still in Orissa, and it's Dr. Sambit Das, who has got numerous publications in national and international journals. He has written, authored textbook chapters. He's been a principal investigator in phase 3 clinical trials. He's a secretary of the Endocrine Society of Orissa, a scientific secretary of ESICON 2018, which we cherish so much, that we attended and learned so much from. So he talked to us about another, a very common problem of uncontrolled hyperglycemia in diabetes. And I suppose he'll concentrate on type 2 diabetes and hopefully will show all of us a way to manage this issue. So over to you, Sambit.
Thank you, sir. Just let me share my slides. So, is my slides visible?
Yes, sir, very much.
Absolutely. Yeah.
Very good evening, respected doctors.
Yeah.
Volker Chaudhary, sir. A very good evening. So,
sorry, I'm sorry. I got the topic a bit wrong. So it's primarily focusing on postprandial hyperglycemia. Yes. We have uncontrolled hyperglycemia coming up later. So for now, it's postprandial. Yes, right. Sambit.
Right. So a very good evening, everyone. And as Sir has introduced that I'll be discussing on importance of postprandial hyperglycemia and the targets and tools how we should manage it. So the agenda of my today's presentation is that I'll tell about importance of postprandial hyperglycemia, how it is important, goals for postprandial euglycemia. So what should be our goal in for PPG? Whether 1 hour versus 2 hour PPG is important, because that's a very big confusion among all the physicians, what we should do. Tools and techniques to achieve the postprandial euglycemia, and that includes various drugs, injectables, diet and exercise. So this will be my flow presentation. So coming to importance of postprandial hyperglycemia, if I can show one of the article which was published by Monier et al., you can see that a given person who takes breakfast, lunch and dinner almost spends 18 hours a day in the postprandial state. So that's the importance of postprandial hyperglycemia. And in the same group by Monier et al., in the Caucasian population, when they have tried to find out the importance of fasting plasma glucose and the postprandial hyperglucose in how they are contributing to HbA1c, you can see that if the HbA1c is higher, the higher contribution comes from fasting plasma glucose, and once the HbA1c is lower, the higher contribution comes from the postprandial blood glucose. But that is not the same in the Asian subcontinent, because the article by Wang et al., it has shown that even if the sugar is, the HbA1c is higher or the HbA1c is lower, the contribution of the PPG to the HbA1c is more compared to the fasting plasma glucose. So in the Asian subcontinent, maybe we are more of rice eater or carbohydrate eaters. The contribution of the PPG to an HbA1c is much more for PPG compared to the fasting plasma glucose. There are n number of studies to show that postprandial hyperglycemia is bad for both the micro and the macrovascular complication, mostly for the macrovascular complication. And these are the numerous studies that has been done to give us evidences. And the diabetes intervention study has shown that PPG is an independent risk factor for MI and the cardiac death. The HHS study has shown that association of PPG with fatal coronary events and overall coronary events. Enhance 3 has shown increased prevalence of retinopathy and nephropathy. That's actually microvascular complication related to PPG. Funagata study has shown IGT is a risk factor for CVD irrespective of IFG. And the famous DECODE study has shown that whatever may be the fasting, if the PPG is higher, that is contributing more to the cardiovascular outcome. And the other studies has shown predicts all cause and CSD mortality with high PPG. So these are the evidences. On the basis of that evidences, the IDF has proposed the mechanism of PPG producing poor cardiovascular outcome, and they have actually formulated a wave theory in that high PPG can actually form like a wave, and they will damage the endothelium at the end. And that wave contains hypertriglyceridemia, antioxidant consumption, increased LDL oxidation, and factor 7 consumption, and finally leading to oxidative damage on the endothelium. So these were the postulation of how PPG is bad for the endothelium, to the vasculature, and to the heart in total. The recommendation from IDF guideline on PPG is that, is post-meal hyperglycemia harmful? These are the evidences, and these are the level of evidences. PPG has been associated with macrovascular disease. It's level 1 evidence. It is associated with retinopathy. It is associated with malignancy. High PPG has been shown to be associated with cognitive impairment, particularly in elderly people. And it has been associated with abnormal carotid intima media thickness and decreased myocardial blood flow and myocardial blood volume. High PPG has been also shown to be associated with oxidative stress, inflammation, and endothelial dysfunction. For that reason, postprandial hyperglycemia is harmful, and postprandial hyperglycemia need to be treated. So the recommendation is that PPG is harmful and should be treated by the IDF 2011. Coming to what should be the goals of postprandial euglycemia, or what should be the target of PPG? Now the ADA 2020 is clear in that the PPG has to be less than 180 milligram per deciliter. And they've actually told that postprandial glucose may be targeted if A1C has been achieved and fasting has been achieved, and then the PPG has not been controlled. Postprandial glucose measurement should be made 1 to 2 hours after the beginning of the meal, generally peak levels in patients with diabetes. So they've actually given a broad criteria that between 1 to 2 hours you can check the PPG. For pregnant patient, the fasting should be less than 95, but 1 hour PPG should be less than 140, and 2 hour PPG should be less than 120. I'm not going into pregnancy postprandial hyperglycemia, but these are the recommendations. Now the third and important agenda is to discuss what about 1 hour PPG and what about 2 hour PPG, because the physicians are always confused whether they will do 1 hour or 2 hour PPG and what should be the target. Now, what should we choose, whether it's 1 hour or 2 hour PPG? Anyhow, both are bad and both are villains. So let us see the evidence in favor of 2 hour post-glucose and mortality. And the DECODE study is the best study to say that whatever may be the fasting plasma glucose, if the 2 hour PPG is high, that leads to various cardiovascular outcome. And there are many studies to support, or there are evidences to support that 2 hour post-meal hyperglycemia exerts harmful impact on the carotid intima media thickness. It may lead to all-cause or cardiovascular mortality. It may lead to congestive cardiac failure in the Honolulu Heart Program. High 2 hour PPG has been a risk factor for CVD and mortality. And other studies has also similarly shown that high 2 hour PPG is more important. But there are studies in favor of 1 hour PPG also. And because they have told that in 80% of the patient, post-meal glucose excursion happens before 90 minutes. That means before 1.5 hours. 55% of patients had a peak at 60 to 90 minutes. The mean peak value after breakfast is 70 plus minus 23 minutes. So they suggest that almost 1 to 2 hours in between the PPG is the highest, and that has to be targeted. And the best evidence comes from one of the Israeli study, which was published in 2018, and that's the clinical implication of 1 hour PPG control. That's a 33-year follow-up study of Israel study of glucose intolerance, obesity, and hypertension. And they've actually found out the survival curves of 1945 individuals according to the baseline OGTT, 1 hour and 2 hour PPG. And this is the survival graph you can see on the left side, and it's the follow-up of 33 years. And they've divided the people on the level of glucose tolerance as Group A, Group B, Group C, and Group D. Group C and Group D has got 2 hour PPG in the IGT range, that is more than 140 or between 140 to 200. And we all know that IGT has been associated with various mortality and various cardiovascular outcome. But what about Group A and Group D? Group A and Group B are basically 2-hour ppg is less than 140. That means they're absolutely normal in terms of the glucose tolerance. But Group A has got 1 hour ppg less than 155 and Group B has 1 hour ppg of more than 155. And there they've shown that if the 2-hour ppg is normal, but 1 hour ppg is more than 155, it increases the mortality by 28%, increases the risk, and the hazard ratio is 1.28. So this study actually tells that 1 hour ppg can actually predict the mortality in this particular follow-up study. So optimum ppg control, we have good evidence on 2-hour ppg, and another study by another study has taken 529 patients with type 2 diabetes with 77 CV events, and they have also told that 2-hour ppg is more predictive. Clinical implication of 1 hour ppg we have studied from this Israeli study, and 1 hour ppg might be more dangerous than 2-hour ppg simply because glycemia is highest at 1 hour, because theoretically the glucose is highest at 1 hour. And 1 hour ppg is a strong predictor of developing future type 2 diabetes to 2-hour post-glucose test. And endothelial function is always worse at 1 hour than at 2 hour. So these were the evidences, and there is a very nice review on the 1 hour ppg by Antonio Cerello, which was published in 2017. So there is still a confusion whether it's 1 hour and 2 hour. I think the ACE and the Canadian Diabetes Association has been very clear that 2 hour post meal should be the target. ADA, ESD, and IDF has still kept as peak postprandial blood glucose between 1 to 2 hours. But whatever may be the discussion, I think more evidences are in favor of 2 hours in non-pregnant patients. So coming to the tools and techniques to achieve the postprandial euglycemia, diet is one of the most important part by which we can reduce the postprandial blood glucose. And we have alpha glucosidase inhibitors, sulfonylurea meglitinides, prandial insulin, and GLP-1 analogs. These are mostly targeting the postprandial hyperglycemia. Dietary intervention, if we are taking low glycemic index, then probably the ppg would be lower. There are some interesting facts which I came across, that high fat slows down the glycemic peaks. Similarly, solid can slow down than liquids, and the cold foods can reduce the postprandial peaks rather than the hot food. So these were few of the evidences regarding the diet. What about physical activity? Muscle use soon after eating can actually lead to accelerated glucose absorption, digestion, and glucose uptake by the muscles, and improve the after meal control. And to substantiate that, there is a very nice study done at PGH Chandigarh by Dr. Bansali et al. They've actually done 10 minutes exercise after each meal, and they've compared it with 30 minutes of exercise at a given time of a day, once in a day, and it is a crossover design, and they could find that there is a significant reduction in the postprandial blood glucose if the exercise is done just after food or just after the meals. Alpha glucosidase inhibitor, we all know acarbose, voglibose, miglitol can reduce the postprandial hyperglycemia, and the mechanism is very clear that these drugs inhibit the alpha glucosidase. Alpha glucosidase is an enzyme which degrades the disaccharides to monosaccharides. So if you are blocking that, then disaccharides won't be degraded. So there is no postprandial glycemic excursion, or there is a lesser ppg peaks. We have 3 drugs, acarbose, miglitol, and voglibose. Subtle differences among them. Intestinal absorption is minimal with acarbose and voglibose, but the GI symptoms is minimal with voglibose in comparison to acarbose and miglitol. And these are the dose ranges. Other drugs which can predominantly reduce the postprandial glucose is ripaglinide and nataglinide, non-sulfonylurea secretagogues, and they can actually lead to more postprandial glucose control than the fasting plasma glucose control. Prandial insulin is another important thing which reduces the postprandial blood glucose mostly, and these are the studies where first glargine was given, tried to control the fasting, but if the HbA1c is higher, we can go with once a day prandial or twice a day prandial or thrice a day prandial in terms of basal plus, bolus, and basal bolus. So that can reduce the HbA1c further, and that can control the postprandial blood glucose in a nicer manner. Profiles of prandial insulin, we have many prandial insulin like regular insulin, aspart, lispro, and glulysin. We know that the modern faster acting insulin like aspart, lispro, and glulysin has got shorter onset of action, peak at the earliest, and it goes down at the earliest. And if this is the normal pancreatic glucose secretion, this is the regular human insulin with the onset later, peaks later, and goes down later. The modern rapid acting insulin are more of physiological in that it is quicker in onset versus recombinant human insulin. But there is other newer insulin like ultra fast insulin, which have quicker onset of action, and advantages of post-meal dosing flexibility up to 20 minutes can be there. Coming to the last, that is the GLP-1 receptor agonist. Again, we have different types of GLP-1 receptor agonists like shorter acting GLP-1 and longer acting GLP-1. Shorter acting GLP-1, apart from reducing the appetite and acting on the pancreas on alpha and beta cells, it has got predominant action on the GI motility also. And once the GI motility is slowed down, the postprandial glycemic excursion is also lower. And for that reason, we call the shorter acting GLP-1 receptor agonists like exenatide or lixisenatide are predominantly the PPG controlling rather than the longer acting like dulaglutide or semaglutide. So that with that, I come to the end of my presentation. High postprandial glucose leads to higher micro and macrovascular complications. Postprandial euglycemia is required for a better A1C control. Postprandial glucose to be targeted at less than 180 milligram per deciliter. Until now, we have 2 hour peak postprandial glucose should be less than 180. Appropriate use of various tools and techniques to be used for postprandial euglycemia. So with that, I'll end my topic. Thank you for the patient hearing.
Thank you very much, Professor Sambit Das. As expected, it was crystal clear, very well enunciated the importance of postprandial hyperglycemia and how we should better control. We'll once again take questions at the end. So we come back to you, Sunil. Can we have his introductory slide once more? Dr. Sunil Kota.
So we can proceed with the presentation. You already.
Okay. All right. Okay. So you then share your slide. So you can take that down. Sunil Kota is from Behrampur, Orissa, and a brilliant young endocrinologist. Yes. So you can take this one down so that Dr. Sunil can present his slides. Yeah.
Yeah. Actually, I have deliberately stopped sharing my video so that the presentation becomes hassle-free. First of all, thank you so much, Bankar sir. Iconic personality, I should say, whom we used to look up to during our residency days and now also during our practice. We all understand that everybody has talked about the organs which are affected by diabetes and we are sparing none. And we think, yes, we have evidence to suggest that it is also involving brain. So this would be my outline of today's presentation. First of all, briefly about different era of diabetes, different timelines of diabetes. Was proposed as a lifestyle disease by Susruta, who also made it a point to mention lean diabetes and obese diabetes. Then Gallen thought that it is a renal disease. It is not able to retain the glucose in the body and it is excreting glucose through urine. Paracelsus for the first time thought it to be metabolic disease. Then the experiment by Oscar Minkowski was further carried out by Banting and Best, labeling it as a pancreatic disease. And the Robert Turner, who happens to be the father for years at the end of this study, said that it is a micro and macrovascular disease. In modern era, we are also trying to point our fingers to the brain. So why are we focusing brain? Because it has been recognized for more than 100 years. And look at the seminal paper way back in 1922, when it was told that people with type 2 diabetes perform poorly on tasks involving cognition and memory. And we have another entity called diabetic encephalopathy, which is an uncommon entity characterized by structural changes, neurochemical, electrophysiological, and degenerative. Most of the times it is overshadowed by diabetes complications, but now that the prevalence of diabetes is increasing in both males and females, the life expectancy is going up in both the sexes, we are seeing more of these. And a number of mechanisms have been proposed to explain the hyperglycemia-induced brain damage. It is stated that there is the small blood vessels supplying white matter undergo ischemic changes, giving rise to a change called leukoirosis. which also gives rise to inflammation, oxidative damage, and amyloid deposit. Chronic hyperglycemia sometimes can reduce the blood supply to the brain, giving rise to hypoxic damage. The cardiac autonomic neuropathy associated with diabetes can give rise to tachyarrhythmia, which can also potentiate multiple infarcts. It is also stated that in elderly people, there is a chance of visual and auditory impairment, which gives rise to social isolation and some sort of cognitive decline. And one of the very important factors is the coexistence of hypothyroidism and vitamin B12 deficiency, which can also affect the cognitive function. Now let us look at the impact of insulin in the brain. And these are the areas where you can see the oral glucose intake stimulates these areas expressing insulin receptor. Those are present on olfactory bulb, hypothalamus, cerebral cortex, especially the prefrontal cortex and the entorhinal cortex, the hippocampus and cerebellum. And how do we see the action of insulin on brain? This has been told to us clearly that if we can sniff the neuropeptide, this can go transnasally direct to the brain, so that the impact of the same neuropeptide can be known. And as you can see from this particular slide, if a person is taking or sniffing a neuropeptide or the insulin in this case, you can see the CSF concentration of insulin is going up, whereas on your right hand side there is the plasma concentration of insulin, which is not actually changing much. So this is the method by which it is examined. How do we change it? How do we observe? Only increase in the central insulin level, sorry, cerebral insulin level. So it has receptors in various brain areas. Hippocampus, it has memory formation. Hypothalamus, as we all understand, it has impact on energy homeostasis and it regulates the food intake. Fusiform gyrus, it is a processing of positive emotions, reward and object recognition. And prefrontal area, when it is activated, there is an inhibitory control of eating. And hypothalamus, as we all understand, there is an appetite center, there is a satiety promoting center. In lean patient, when we give insulin intranasally, there is an increased cerebral blood flow to the lateral areas of hypothalamus, giving rise to satiety promotion. Whereas in obese, if we give intranasal insulin, there is something called brain insulin resistance. So the cerebral blood flow to those areas will also not be ameliorated. And there are some possible causes of brain insulin resistance. Either it can be during the fetal age or during the stage or during the adult stage. Fetal stage, it is stated that if mother's metabolism is not good, that means if she is obese, her sugar is not under control, she can pass on the bad things to the ingrowing fetus. Then also it is stated that high intake of fatty foods in the adult time and in the adult stage, there can be some sort of alteration in the blood-brain barrier, which can give rise to brain insulin resistance. And there are studies which have told us that if you can modulate the brain insulin sensitivity, the peripheral insulin sensitivity would also be modulated in a positive sense. So here is a hyperinsulinemic euglycemic glucose clamp, and you can observe that after a steady state is achieved, if there is insulin sensitivity, to match with the insulin infusion, you need to give more of glucose. But if there is a state of insulin resistance, then with lesser glucose also, you can match up with the insulin infusion. So in the subsequent slide, you can see that in this patient, once the steady state is achieved, then the spray is given at one point of time. And in the patient who is receiving spray versus placebo, the white dots, white circles, you can see once insulin spray is given intranasally, there is higher glucose infusion rate requirement that shows the insulin sensitivity is increasing peripherally, which calls for more glucose infusion. But again, the insulin sensitivity index is actually going up in a lean person, but it is not going up significantly in a overweight person. And again, they have looked at functional MRI changes in different areas, especially in this study, they have looked at hypothalamus. So once the nasal insulin is given, the previous study has shown that there is improvement in peripheral insulin sensitivity, but which organ is the mediator? And here he says that there is an increase in hypothalamic blood flow, which indirectly is manifested in form of increased peripheral insulin sensitivity. But again, diabetes is associated with several of dementia and cognitive dysfunction. We all understand that midlife intake of saturated fatty acid is associated with early cognitive decline as per some epidemiological studies. On the contrary, it is stated that if you take more of complex carbohydrate and saturated and beneficial fats, it is going to reverse the trend. And apart from that, coexistence of hypertension, triglyceridemia, bad glycemic control period over a long period of time again is associated with dementia. And the number of mechanisms are proposed. Just for completion's sake, it is stated that there is impaired synaptogenesis, altered synaptic plasticity, mitochondrial dysfunction, increased tau phosphorylation, and that actually goes on to lead to formation of increased amyloid and neurofibrillary tangles. And the two basic types of dementia in elderly, whether it is a vascular dementia or it is a Alzheimer's dementia, that again is the question which we are going to discuss subsequently. But you can see in this particular meta-analysis in 2006, it says that overall there is a 73% increase in overall dementia in patients having diabetes. And if we look at the vascular diabetes, this is a meta-analysis of 13 studies, you can see 130% increase in vascular dementia. And look at the individual studies. Most of these studies are on right hand side of the vertical line. When we talk about the Alzheimer's type of pathology, overall you can see there is a significant 60% increase, but there are good number of studies which are crossing the midline. So again there is a tendency to suggest that most of the causes are vascular in origin. This probably puts this discussion to end. This is a study in 2016. On upper half you can see the cerebrovascular pathology contributing to dementia, and the lower half you can see the Alzheimer's disease contributing to dementia. The cerebrovascular pathology, all the majority of these studies are showing significant increase in ratio, but the Alzheimer's disease, it is not showing significant increase in most of the studies. So number of risk factors have been proposed: increasing age, genetic predisposition, systemic inflammation, smoking, cardiovascular disease, coexisting hypertension and dyslipidemia, because most of these studies have tried to point fingers at the vascular cause of dementia. And as we all understand, Alzheimer's is also a state of type 3 diabetes. This is a very important study from Finland, which has looked at individuals with or without ApoE formation. All individuals, there is a significant increase in cumulative incidence of dementia, but patients with ApoE, they want to have higher chances of dementia. But what exactly is the takeaway point from these studies? Look at the last line, the model 4, which says amyloid formation and the tangle formation, which are pathognomonic of Alzheimer's disease, they are not getting significantly increased, whereas on extreme right you can see the cerebral infarct is the most commonly found abnormality in the patients having diabetes. And there are a number of other mechanisms being proposed. One among them is the hyperamylinemia, and apart from that there is role of Huntington chorea, there is Friedreich's ataxia, and number of others conditions are also being pointed at. There are some subtle cognitive changes in this study in 2014. It says that there is impairment of intelligence, language, attention and concentration, and verbal memory domain is significantly reduced to the tune of 72%, and it is generally 10% lesser than those without diabetes. It is roughly equivalent to persons suffering from jet lag, where your verbal reasoning capacity gets blunted to some extent. And there are some subtle cognitive changes, as you can see from this study, the Utrecht diabetic encephalopathy study. The attention and executive functioning is reducing significantly in type 2 diabetic patients over 4 years. There is progressive increase in diabetic dementia, and there is reduction of cognitive activities. So this article in Lancet Neurology 2015 talks about some of the aspects, like it says it occurs in all age groups, they slowly progress and mostly manifest in the later ages, and the subtle changes of cognitive function typically 0.3 to 0.5 standard deviations lower than in people without diabetes. And do we have any risk evaluation score? This was a study in 2013, prediction of 10 years risk of dementia and type 2 diabetes. They have taken 3 different parameters. First of all, age. Second is the coexisting condition like acute metabolic event, microvascular disease, diabetic foot, cerebrovascular cardiovascular disease, depression, and his education. Then add up all to the points, and what it says is that compared to -1 where we have only 5.3% increase in risk. If the values go up, there is a 73.3% when the score is between 12 to 19. But again, it is not for individual prediction here, but only used for RCTs. But we do have some data to suggest that yes, in the future we can come up with a score. So what are the management options? So we have the baseline decline, and that no one can halt. Then there is accelerated decline. Can that be halted? We have options like intensive glycemic control. This was a 6-year RCT in 2012. Intensive versus standard treatment, there was no improvement in cognitive functioning. Again, a 40-month RCT, again it says that intensive versus standard, there was no improvement in cognitive functioning. But then again, on MRI, there was a slower brain atrophy. Again, in that particular study, they have looked at the blood pressure arm. They have divided into intensive blood pressure lowering, less than 120, standard less than 140. But again, no improvement in cognitive functioning. But with intensive blood pressure lowering, there is a faster brain atrophy rate on MRI. And what about the late life dementia? Do we have any drugs? You will be surprised to know that the Carolina and Carmelina, which has used linagliptin, have looked at several parameters, one among them being the mini-mental score examination, the visual function score, and they have used 2 other scores to look at the slowing down dementia aspect of linagliptin. Again, there are studies which say that intranasal insulin increases the CSF insulin and improves memory within 30 minutes in young healthy adults without changing plasma glucose or insulin. Again, there are some studies in the animals to suggest that insulin-like peptide goes up in the hippocampus, amygdala, and all other regions having insulin receptor. This was the study where nasal insulin was studied to see how it can impact the forgetfulness, and the summary was there was, after 4 months of intranasal insulin, there was preserved or improved cognitive and functional abilities, preserved cerebral metabolic rate of glucose in areas having the Alzheimer's disease pathology, excellent compliance and safety, larger, longer multi-site trial currently being planned. To my surprise, yes, there was an article in 2014 in which says that sulfonylureas in general, they can improve the intelligence scores, visual attention deficit, gross and fine motor skills, gesture conception and realization. Thiazolidine, it is shown to inhibit the amyloid beta production by modifying the ApoE4 gene polymorphism. RCTs have failed to demonstrate its benefit. Metformin, you can see the words mentioned on the blue fonts are the ones which are showing there is an improvement in cognitive function. But again, there are studies which say that there is worse cognitive performance which was associated with metformin use. So the answer would be equivocal if we go on to use metformin. But very standardly, it states that high saturated fat and high glycemic index bad diet increases the markers of AD pathology and oxidative injury. This is one such agent, agmatin, which is a NMDA antagonist. So I'm just trying to tell you a spectrum of drugs which are available at our doorstep. What about exercise, dementia, and physical activity? I deliberately tried to project this slide because most of the times we are told that exercise improves cognitive function, but this is one such study. I'm just going to tell you the conclusion. It was published in 2018. It says that the exercise program might worsen cognitive impairment, although the difference is small and of uncertain importance. But again, what the master says, the Mayo Clinic proceedings, besides a brain neuroprotective effect, physical exercise may also attenuate cognitive decline via mitigation of cerebrovascular risk, including the contribution of small vessel disease to dementia. So it should not be rather overlooked as an important therapeutic strategy. So lastly, does hypoglycemia has an impact on brain? It is stated that repeated hypoglycemia gives rise to neuronal death in areas like cerebral cortex, basal ganglia, and areas of hippocampus like dentate gyrus and cornus ammonis. And in type 1 diabetes, here you can see the patients were average age of 7 years, and the ones who have 5 or more hypoglycemic events per year are associated with 10 decline in IQ. But the same was not reflected in DCCT, EDIC, in spite of repeated hypoglycemia, the IQ score was not going down, but it was stated that the mean age of the population was 27 years. By that time, the IQ is almost fully developed. And this is there is a relation between severe hypoglycemia and occurrence of dementia as per the study in JAMA 2009. This is a study on type 2 diabetes. It states that as the number of severe hypoglycemic episodes go up, the hazard ratio for having dementia also goes up. Again, you can see the patients having severe hypoglycemia represented by the blue column and the green one representing no severe hypoglycemia. There is a significant cognitive decline. About RCTs, the accord hypoglycemia is more common in intensive one, but there was no effect of intensive treatment on cognition, but poorer cognitive function associated with an increased risk of severe hypoglycemia. So probably there are some confounders which have to be taken care of, like patients with type 2 diabetes and severe hypoglycemia are more likely to have insulin, longer duration of diabetes, older age, and more sort of complication, which push them to occurrence of more of macrovascular complications. So that brings to the conclusion, yes, we all understand that diabetes is associated with cognitive dysfunction. With increase in prevalence and increase in life expectancy, we are going to predominantly induced vascular injury as per the existing studies, but again, there is a significant in Alzheimer's also. The conventional treatment does not have intensive glycemic control, does not. Exercise definitely is of help. What medications to use? Metformin has equivocal value. Pioglitazone is somewhat promising. Linagliptin, yes, there are studies, but I couldn't come to a conclusion reading that particular study. But of course, avoidance of hypoglycemia would go a long way. Thank you all for the patient listening. It's over to chairperson.
Thank you, Sunil, for brilliant exposition, taking us through the effects of diabetes on the brain, and also possibly showing how brain could affect diabetes as well. And I now would invite all the four speakers, Dr. Nilakshi Deka, Dr. Arundhati Dasgupta, Dr. Sunil Kota, and Sambit Das, to answer the questions. Let's see what we have. So we have a few for Dr. Nilakshi. So this is Dr. Sujit Lenka, who has a question about the burden of NAFLD in pediatric population. And he's also asked about female gender and NAFLD.
So, yes, sir. So, sir, regarding the first question of NAFLD affecting children, yes, the pediatrics age group is becoming, it's like becoming a ticking time bomb, where because of increased use of processed food or saturated fats, NAFLD and type 2 diabetes at a younger age are becoming very common and frequent and rampant. Regarding the second question of gender differences in NAFLD, it is seen that it is usually the male gender who is more predisposed to having NAFLD, but women who are in the postmenopausal age group, they can also have a greater chance of having NAFLD. So premenopausal women, it's a negative risk factor, but postmenopausal women and men, they are more predisposed to having NAFLD than the female gender.
Okay, fine. For Dr. Arundhati Dasgupta, pioglitazone is something that may be used for NAFLD, as Nilakshi has suggested. So let's say your patient whom you showed with hypertension, uncontrolled hyperglycemia, dyslipidemia, maybe that gentleman also has got NASH and also has got retinopathy. So what is your view about the use of pioglitazone in presence of diabetic retinopathy?
So in the presence of diabetic retinopathy, pioglitazone is not a contraindication unless there is presence of macular edema. So if the patient has macular edema, definitely pioglitazone would not be a molecule that would be used. Otherwise, in my patient, because the BMI was slightly on the higher side, again, pioglitazone would not really be a drug of choice there. In a maybe a leaner individual who's got mild retinopathy, their pioglitazone may be used without evidence of any macular edema. There we can.
Right. Yeah. So if we come down to Dr. Sambit Das about postprandial hyperglycemia, so Dr. D.K. Das Mahapatro wants to know the role of DPP4 inhibitors. I feel that you have touched upon it amongst the agents to control postprandial hyperglycemia. Can't see Dr. Sambit Das. Is he around? Anyway, maybe he's lost the link. So DPP4 inhibitors do have a preferential effect in control of postprandial hyperglycemia. And this, of course, is related to its mechanism of action of meal-related release of incretins and their breakdown being blocked by the DPP4 inhibitors. And so they are considered amongst the agents to control postprandial hyperglycemia, apart from the alpha-glucosidase inhibitors or the short-acting secretagogues like repaglinide. We have a couple of questions for Dr. Sunil Kota. One is, this is from Dr. Prakash Chandra Mohanty. Can intranasal insulin be supportive to inject, I don't know what he meant, to inject insulin or oral hypoglycemic agents? That's not clear to me. The question, does it make sense to you, Sunil? No.
No, sir, I am also not able to get it.
Right. So you did mention about intranasal insulin, about improving cognitive function. So we also know that there have been attempts at nasal delivery of insulin and pulmonary delivery of insulin. So would they not cause systemic effects? Could they not lead to hypoglycemia?
Yes, sir. Actually, they would actually. Initially, when the alternate modes of insulin delivery was looked at, they were basically aimed at reducing the blood glucose only, as you all understand from the one which is Afrezza one, which is not in use. Yes, they predominantly are used for reduction of blood glucose, but maybe in the studies which I have quoted, where they have used it a very probably subtherapeutic doses only to look at the impact of insulin on cognitive function and peripheral brain sensitivity, peripheral insulin sensitivity. But again, the predominant usage is to definitely reduce the blood glucose.
Right. Another question, this is by Dr. Sanjeev Chakravorty. It's to do with metformin causing vitamin B12 deficiency, and metformin is sort of the backbone of our treatment of type 2 diabetes. So should we be giving B12 to everyone who is on metformin? What should we do?
So it's for me, I think.
Yeah.
Because I touched upon the issue of B12 deficiency contributing to cognitive decline. Yes. Actually, when I was going through the literature, recently I could come across two studies. One was from Oman in 2019 and one was from 2017. I couldn't look at the country, in fact. And where they have stated that compared to metformin non-users, metformin users have a twofold increase in vitamin B12 deficiency. And overall, even without metformin usage, the vitamin B12 deficiency in Oman was around 20 to 25%. And if you look at the ADA guideline also, correct me because Subhankar sir is there, so I can dare to talk about this. Probably, I think I would definitely go for universal B12 recommendation. Subhankar sir, please.
So well, I do not do so yet in my practice, and my observation is that the vitamin B12 level possibly definitely drops from your pre-treatment level after you started on metformin, especially if it's been for long. But in most instances, it does not dropped to really deficient level. That's my observation. Of course, in specific subgroups, especially in many vegetarians who otherwise are deficient in their diet in vitamin B12, they can and they do develop. So I would generally not give a blanket vitamin B12 along with metformin at this point of time. And of course, but we have to be, what should I say, alert enough to try and do those tests and selectively use vitamin B12.
So would you be preemptive in treating, maybe giving to all vegetarians in our setup?
Well, possibly, I mean, because it's not likely to be harmful. One may do so, but I admit that at this point of time, that's not part of my practice. Now, I can see amongst the panelists also Dr. Rana Bhattacharjee and Professor Sujoy Ghosh. Would they also share their practice?
So
Why am I
personally do not routinely supplement it, sir. Actually, but again, in elderly population and those who are vegetarian but do not take a milk adequately, I remain a bit cautious regarding the symptoms of peripheral neuropathy. And there, maybe empirically, I sometimes give shots of vitamin B12. May not be oral for long, but intermittent shots. So
and I find,
B12.
and before I come to Sujay, and I find a little bit surprising that there are studies which suggest that for metformin-induced vitamin B12 deficiency, you need to give large
calcium
doses. 15, calcium also does help, but 1500 micrograms of vitamin B12 daily is proposed dose. Why should one need such large doses? I don't understand. Yes, Sujay.
Sir, some of the labs actually, as part of the entire gamut of tests that they do provide a vitamin B12 levels, and particularly the section of society that Sunil was talking about, the vegetarian population of Kolkata. Most of the times, the reports are actually higher than normal. Either
yes.
they have, either they have already been given the vitamin B12 by some other doctor. And particularly that community of Kolkata often takes injectable vitamin B12 without any test, without any indication. So I'm not very sure. I particularly, like Rana also said, and like you said, it's not part of my treatment as part of a routine. Unless and until there's something really worrying me, I don't even test. And the problem is, even if you do test, what do you test? Is it just the B12, or you look at other things as well?
Right. We had a few other questions related to postprandial hyperglycemia. How do you detect it? We don't still see Dr. Sambit Das, but I'm sure self-monitored blood glucose, or even now the availability of continuous glucose monitoring, would be picking this up more often, more easily. So I think we had a very interesting session, excellent speakers, and beautifully chosen topics. And we are alerted to the importance of looking for non-alcoholic fatty liver disease. At this point of time, apart from knowing it as a risk factor, not only for hepatocellular disease long-term, but also for cardiovascular disease, we yet possibly do not have the best possible medications, proven medications, to alter the course of the disease apart from lifestyle. We do have vitamin E, we do have pioglitazone. Possibly some of the other bile acids may show some better results, like obeticholic acid, but at this point of time, possibly that's all we have. And then about retinopathy, we are correctly sort of informed that we need to screen for it, especially in women going in for pregnancy. And we need to be aware that it's not just glucose control. There are other factors like blood pressure, lipids, etc., could also contribute to the management of retinopathy or prevention of retinopathy. In this regard, I think we have another question for you, Arundhati, that's about fenofibrate and retinopathy progression. What is the recommendation? So do you suggest that all patients with diabetic retinopathy be given fenofibrate?
that the data with fenofibrate and retinopathy was in favor of fenofibrate came from the ACCORD-I and the FIELD study. But we also need to remember that they were not primarily looking for this. Those were not the primary endpoints. Also, they were not using, there were certain characteristics like OCT and macular edema, which were not studied in great details. And most importantly, though both the studies did show decrease in the progression of diabetic retinopathy, they did not show any benefit in terms of visual acuity. So that has to be kept in mind. Nevertheless, some countries like Australia, they've taken it up as a guideline that retinopathy progression needs to be stopped with the use of fenofibrates. But other countries have not, other guidelines have not as yet accepted the role of fenofibrate in as an active molecule to be given for prevention of progress of retinopathy.
Right. So at this point of time, it's not yet general practice, but maybe in individual cases, one may think about it. And then we came to the beautiful presentation by Dr. Sambit Das, looking at postprandial hyperglycemia and trying to decide whether it should be 1 hour glucose or 2 hour glucose. He did say that by and large, the data are more, or Sambit is back. The 2 hour glucose has got better amount of evidence. But if you want to look at the peak postprandial glucose, possibly you get that somewhere between 1 and 2 hours, maybe 90 minutes or thereabouts. And so if you could address that, it may be even better in terms of reducing the oxidative stress on the endothelial dysfunction. But universally, still, I think it's mostly the 2 hour postprandial glucose that we are looking at, and we have a variety of agents to address. And then finally, we have already discussed just now with Dr. Sunil Kota, the interesting association between diabetes and the brain. And the important issue here, of course, is cognitive decline would also give rise to more difficulty in the patient controlling or taking care of his or her own diabetes, doing the tests, taking so many insulin injections, and so on and so forth. So picking up those cases of cognitive decline, especially in the elderly individual with diabetes, is important. And I find one of the very easy tests to do, even at the in our clinic, is the clock face drawing test. You ask the patient to draw a clock face and ask him or her to show particular time, maybe 15 minutes past 7, and then see how they struggle, people with cognitive decline. And these individuals obviously will be, we must make sure that we do not advise them very complicated regimens, even if we are not able to achieve the best glucose control. Maybe a single shot of insulin, if at all the subject needs insulin, should be all that we should be happy with. So with these few words, I'd like to thank each one of you, Dr. Nilakshi Deka, Dr. Arundhati Dasgupta, Dr. Sambit Das, and Dr. Sunil Kota for wonderful deliberations, and also to our audience so far. So I hope all of you don't go away, because we still have more to go. Excellent 3 more speakers and excellent topics. And we will still have more of the evening to share and learn from. Right, so we go over to the next part, which is designated as point of view. And the first person to take this up is Dr. Dayanidhi Meher, who is assistant professor at the Kalinga Institute of Medical Sciences. And we are very happy that, very proud that he chose to do his DM program with us in Kolkata. And we had a long sort of a relationship with him. And he has been quite active in the academic field and has published articles in different journals. So he is, of course, as we mentioned, in Bhubaneswar, the Kalinga Institute of Medical Sciences in Bhubaneswar. And so over to you, Dayanidhi, to talk to us about what is your topic.
Yeah, verified trial, sir.
Yes, that's very important. A clinical trial that's to do with vildagliptin metformin combination. So over to Dr. Dayanidhi Meher to discuss the verified trial in brief.
Thank you very much, sir. And I welcome everybody to today's webinar. And in fact, I would rather defer to sir, that rather I was lucky to undergo DM training under sir.
Thank you,
sir. And today I will be putting my perspective on this verified trial. Yeah, this is the largest long-term prospective trial to look at the glycemic durability of a combination of anti-hyperglycemic drugs. And in fact, there is no such trial prior to this verified trial to look at the glycemic durability. We had certain trials like ADOPT trial, which looked at the glycemic durability of pioglitazone, sulfonylurea, as well as metformin. But in fact, the glycemic durability of PPP inhibitor was not looked at. And in fact, a combination was rather more interesting because in our day-to-day clinical practice, we do use a lot of combination of drugs without knowing the durability, glycemic durability, safety, as well as effectiveness of these combinations. So this, the evidences from this verified trial would support our practice rather. It's a evidence to support our practice. And this is a randomized double-blind parallel group trial to look at the glycemic durability, and it had two co-primary endpoints. First is the incidence of treatment failure with either monotherapy or when compared to combination therapy of metformin and vildagliptin. And second co-primary point was median time to failure with either metformin monotherapy when compared to metformin and vildagliptin combination therapy. And it was found that regarding the primary co-primary point outcome, the incidence of treatment failure was 43% in combination therapy group receiving metformin with vildagliptin, and while it was 62% in the patients receiving metformin monotherapy. And regarding the second co-primary point, that is the median time to failure, it was 36.1 year in patients with metformin monotherapy, while it was 62.1 months in patients receiving the combination therapy, that is beyond the trial period of 5 years. So patients who received the combination of metformin with vildagliptin from the very beginning, the durability of glycemic control was good. It was safe. It was found to be safe and effective. And this is the evidence we have gained, and rather we should feel more comfortable using a combination therapy of these drugs, and particularly in the newly diagnosed diabetes patients who are treatment naive and having a HbA1c less than 6.5, less than 7 to 7.5%.
Right. So Dayanidhi, do you have any explanation for such a finding?
Yeah, both the talks act in have complementary mechanism of action. The this metformin decreases the hepatic glucose output and improves the insulin sensitivity, and at the same time, the DPP4 inhibitor vildagliptin that improves the beta cell function.
No, I know, but why, if we start with both together rather than one after the other, do we see a better response after?
Yeah, because with the combination therapy, we are going to get a better glycemic control early and a sustained glycemic control over a long period of time, and the legacy effect of this control will carry forward for a long period of time. And in fact, the durability of the combination therapy was demonstrated beyond the study period of 5 years.
Right. So that's
yes. This is hypothesis generating, whether we are by this we are going to how much to what extent we are going to prevent the long-term complications. This study is basically to look for the glycemic durability.
Yes, and the starting point. I mean, whether you and I in our routine clinical practice start with two agents for the management of hyperglycemia is the issue. There is definite trial evidence. If it is really borne out, then maybe we have to change our practice in future. But possibly at this point of time, many of practicing clinicians do not do this. But do you think this is strong enough evidence for us to change our practice?
Sir, in fact,
let's come to a specific question. Have you changed your practice? I mean, maybe not in every patient, but in a significant number. And again, I do understand, maybe if not vildagliptin, it may be other gliptins also. So do you think as a concept, this is something that we should be taking on? Of course, one of the issues is that it is not likely to give rise to hypoglycemia or weight gain, which would be considered concerned with other ranges, maybe even with insulin or with sulfonylurea. So it's relatively safe to go ahead with this. So do you think it's going to change your practice or changing your practice? Sir. It is?
Sir,
okay.
Obviously, I do prefer a combination, particularly to, if you are combining vildagliptin with metformin, the dose of metformin you can bring down, and the compliance will be better in terms of the GI intolerance in particular. When initiating therapy with metformin, around 20% of the patients, they do complain of this GI intolerance.
Right. So this
vildagliptin is again a kind of drug that is to be pad and forget. So we need not have to bother about the hypoglycemic part, and again weight neutral, and particularly when combined with the metformin.
Right. So amongst all the speakers in the previous sessions and also the speakers to come, are there any other views on this issue? Yeah, Professor Shujar Ghosh.
Right. Thank you, sir. I think this study has actually triggered a lot of controversy rather than consensus. The American Diabetes Association has jumped in and taken this bit up in the 2020 clinical practice guidance. But like you pointed out very well, how many of us are going to start a double drug combination at such low levels of HbA1c to start with? Because treatment naive patients with type 2 diabetes in any case respond to even much higher A1Cs to start with, and probably none of us are actually going to use double drugs at such low starting points of HbA1c. I think practice differs in different countries, and probably what might have happened is in the countries where this trial was undertaken, follow-up normally is poor. In India, it's poor as well, but it could well be that periods of relatively uncontrolled blood glucose led to less durable effects of whatever drugs, because you give one drug and then it fails and you give the second drug. I'm still not very convinced, though this is pretty robust data in terms of it being an RCT, but I would still want more studies to actually show us the same kind of results. And if so, concept wise, then why not an SGLT2 and metformin to start with, rather than a DPP4 inhibitor and metformin to start with? Sorry for being the devil's advocate.
So any other comments from others? Quick ones, if anyone wishes to comment. Sunil, yes.
Yes, sir. Actually, I would go with Dianethi. As you said, probably submaximal dosage of drugs would also do good, because in my practice also I see a lot of patients having intolerance to metformin. So that basically gets ameliorated when we go for a combination. But as Sujoy sir stated, probably it's not only vildagliptin, maybe something else also which can also chip in.
The other point, traditionally before the new vildagliptins came in, the metformin in the vildagliptin-metformin combination is an immediate release metformin. So if you are thinking of GI side effects, then probably think of two different pills. Though now we have vildagliptin with slow release or sustained release metformin.
Oh,
but at the end, most of our patients, they do not come with, most of our patients, they don't come with a HbA1c of 6.5 to 7.5.
Yeah, that's also true.
We cannot solely rely on this combination in particular. The SARN was better than all of us.
Yeah. So, but I think we need to learn also and not just shut it off. And especially with the availability of cheaper vildagliptin metformin combinations, if this really grows up as a good concept to follow. This may be good in the long run, because ultimately we fail to control the A1Cs in a significant number of patients. If this is a way to go forward, be it so. Right. So thank you very much, Dayanidhi. So
sir,
we
one
now
more
go
thing.
on.
One more thing.
Yes,
We can slightly improve our clinical inertia part.
Yeah.
Rather than step up approach, the combination therapy may do good in that term.
Yeah. Sure.
Sir,
sure.
Thank you. Sir.
Thank you. Thank you, Dayanidhi. So we now go on to very difficult subject, and that's why Dr. Rana Bhattacharjee has been called in to to take care of uncontrolled hyperglycemia. So, and Dr. Rana Bhattacharjee is an assistant professor in the Department of Endocrinology at IPGMER, Kolkata. He is a wonderful academic career, a professional life. He's received various awards from the Association of Physicians of India and also from the Endocrine Society of India. He was the proud recipient of the Dr. A.R. Seth Award, and he has more than 60 publications in peer-reviewed journals. Over to you, Rana.
Thank you, sir. Regarding uncontrolled diabetes, the focus is mainly on two parts. Number one, the part of symptoms of diabetes, which are often there with a grossly uncontrolled diabetes. But that may be less of a problem from the compliance perspective, because most of the patient actually remain more compliant during who are symptomatic. So treating them in a way is relatively easier, unless there is a hyperglycemic emergency, of course, which is a relatively rare phenomenon. But the main difficulty arises to make the patients understand the importance of a long-term problem with uncontrolled glycemic status, and when the patient remains relatively asymptomatic early on. And the legacy effect that we have seen from the classic older studies like DCCT and APPDS, that clearly shows that early glycemic control is definitely beneficial, but it's very difficult to convince the patient that way. I think that's a major hurdle to that. Secondly, the drugs that we can use, at least initially, of course, the insulin may be a very good choice when the hyperglycemia is severe and the patient is symptomatic, or with the other comorbidities like infections or any acute emergencies like myocardial infarction and others. Otherwise, if the patient is not very overtly symptomatic, up to HbA1c of 9, even 10, of course, we can try the combination of oral antidiabetic drugs in a very obese patient. So if they can afford, of course, the combination of GLP-1 agonist along with metformin and insulin can also be used. Other than that, for most of our patients, so what I think can be done, if the blood glucose level was not very high, I mean A1C level is say within the 7.5 maybe, or up to even 8, the drugs like DPP-4 inhibitor and SGLT2 inhibitor works quite well in combination with the metformin. Regarding just the verified trial, there are some group of patients who have HbA1c between 7 to 7.5. So they can well be started with the combination of DPP-4 or SGLT2 inhibitor along with metformin, because even if they are not that compliant, this kind of combination actually takes care of a relatively longer duration of glycemic control. But if the A1C remains a bit higher, possibly we would prefer the drugs like sulfonylurea to start with in combination with metformin. That's what a practical kind of thing. I think there is no such recommendation by any bodies, but many of us follow that if the patient has a relatively higher A1C, which may not be a classic indication for insulin, we often prefer sulfonylurea and metformin to begin with, and we try to continue with that. And after that, we may shift to other agents, or we may continue with these agents. So these are the three practical points, I think, so with the uncontrolled glycemic status, particularly in the beginning in a type 2 diabetes.
Right, thank you, Rana. So what is your view on early insulin use in type 2 diabetes? I know there are seminars, there are talks, and there is also evidence that if you use early insulin, maybe intensively, you may even be able to remit diabetes for a period of time. So do you think that is an option?
Yes, so the studies, those have been done, which has been shown that insulin can have a long-term better glycemic control or even remission in a certain number of patients. So usually the baseline A1C of those, the patients in those studies were relatively high. So in those situations, mostly already use insulin, but the studies where the baseline A1C level was not that high, so the positive result was, the result was not that impressive. So, sir, I think so in a patients with milder degree of hyperglycemia, unless there is other compelling needs like a coexisting infection or other acute situation, so we may not start with insulin because the evidence is not that strong in that subgroup of patient.
Yeah, I would fully agree. If everyone else also agrees on that point, right? Right. So thank you. So we now go on to Professor Sujoy Ghosh, who will take us through an issue which has been there as a debate topic for the last 2-3 years. And Professor Sujoy Ghosh is Professor of Endocrinology in the Department of Endocrinology in IPGMER, Kolkata. He, amongst so many other things, he is editor-in-chief of the Oxford Handbook Series, Southeast Asia edition. He's executive editor of Indian Journal of Endocrinology and Metabolism, and also Thyroid Research and Practice. And he's also associate editor of International Diabetes Journal for Diabetes in Developing Countries. That's the RSSDI journal. And he has had numerous publications, and he's had numerous accolades to his name. He has received the Best Research Award at the Royal Medico Chirurgical Society of Glasgow in 2007. He has received the Best Research Paper Award in Bone Metabolism at European Endocrine Society meeting in 2009, and so on and so forth, and has published over 250 articles. And over to you, Sujoy, to talk us on relative merits and demerits of DPP-4 inhibitors and SGLT2 inhibitors.
Thank you, sir. I think the game is changing. You know, for example, we've had this debate about SGLT2 inhibitors and DPP-4 inhibitors since about 2013-14, some from that time onwards. And they are both very good group of drugs to use. And if I actually have to talk about SGLT2 inhibitors more so, because some of the SGLT2 inhibitors are probably going to be available at a much cheaper price, because so that cost difference between SGLT2 inhibitors and DPP-4 inhibitors, or at least the cheaper DPP-4 inhibitors, that's going to get negated. That's probably going to be a big, big game changer. And particularly if you are going to have very, very affordable SGLT2 inhibitors with the kind of evidence that we have for the major premium SGLT2 inhibitors, SGLT2 inhibitors are going to be used more and more. But if you look at SGLT2 inhibitors in terms of the glycemic control, you know, it might not work like DPP-4 inhibitors across the board. Because firstly, the glycemic efficacy of an SGLT2 inhibitor is dependent on the EGFR. So if with declining EGFR, the SGLT2s are probably not going to be that great glucose lowering agents. And the second thing we all know is that higher your A1C is, the better an oral antihyperglycemic drug does. And the lower it is, the poorer is the glycemic efficacy. This is even more true for SGLT2 inhibitors than, say, for example, DPP-4 inhibitors. That's probably because at a lower level of A1C, the glucose excretion part benefit is probably slightly reduced. So if you're talking about glycemic benefits, DPP-4 inhibitors are going to probably work across the board in terms of renal function, but SGLT2s are going to have certain amount of blunted glucose lowering efficacies. And if you're thinking of that, you know, the safety profile, the DPP-4 inhibitors have proven that they are going to be very safe. It's just like thinking of the old Hero Honda ad. Fill it, shut it, forget it. So DPP-4 inhibitors you can probably use blindly in almost all situations, particularly now when people are doing teleconsultations in COVID times, when you don't know what the renal function is like, what the associated liver function tests are like. And therefore, the safety profile of DPP-4 inhibitors is better than SGLT2 inhibitors. So for the SGLT2 inhibitors, you've got to educate the patient and you've got to educate the physician as well. Why am I saying, we've had so many CMEs and programs? Because, the proportion of doctors who have been prescribing SGLT2 inhibitors has been small. Now with the SGLT2 inhibitors going to be so much cheaper and so many companies bringing in SGLT2 inhibitors, it's going to percolate down the line to lower and lower rungs of physicians who probably will now need to be re-educated or educated about the safety aspects of SGLT2 inhibitors. They have to be taught about the GTIs, about the contraindications that you should not be using it in someone who's insulinopenic, talk about the situations where to stop the drug, just like sick day rules. So those issues will have to be kept in mind. Now, if we keep all of that in mind, SGLT2s scored definitely over DPP-4 inhibitors. And that's predominantly not because of the glucose lowering benefit, but with the evidence of other benefits that SGLT2 inhibitors have. For example, renoprotective benefit, the heart failure benefit, and possibly atherosclerotic cardiovascular benefit as well. And if you look at meta-analysis of SGLT2 inhibitors, we now see we have drugs that could possibly reduce cardiovascular death and could possibly reduce all-cause mortality. And the cardiologists and nephrologists have started saying that these are their drugs which have some glucose-lowering benefits. The other thing that the DPP-4s will have to be mentally be prepared about is that there's going to be again a challenge to the DPP-4 space once oral semaglutide is available. So both very good group of drugs, each with its positives. And remember, type 2 diabetes is a progressive disease. So if you start metformin and it fails, you will need another drug, which Dayanidhi has taught us. We could probably combine vildagliptin or any gliptin with metformin. Even with that, you will have oral hypoglycemic agent failure. So it'll be like, who is A, who is B, who is C, rather than only A, only B, only C. So the sequence of the use of drugs might be different, but all of them are here to stay.
Right. So how convinced are you about the mortality benefit of the SGLT2 inhibitors? For example, at the EMPA-REG, we saw for the first time empagliflozin showing mortality advantage. But if you went on to Emperor reduced, their empagliflozin didn't have a mortality benefit, whereas dapagliflozin, which didn't show MACE reduction, didn't show mortality benefit in declared TMA, now in their DAPA heart failure shows a mortality benefit. So the frivolities of these evidence-based medicine also possibly need to be considered.
I'll answer that question in two parts. When EMPA-REG came out with cardiovascular death benefit and all-cause mortality benefit, everybody was going gaga over empagliflozin and saying that it's the only gliflozin that has these benefits. Now with the Emperor getting published, if you look at the discussion part of Emperor paper in New England Journal of Medicine, they themselves say that people now believe that the results are not consistent across the board in various studies. And this possibly reflects the differences in study designs, which is the point that you've made. The second bit of the answer that I will give you is that myself and Dr. Pradeep Mukhopadhyay, we've just finished a meta-analysis of the 6 RCTs of the SGLT2 inhibitors. So we have CANVAS and CREDENCE for canagliflozin. So we have declared TIMI, DAPA heart failure and DAPA CKD for dapagliflozin. And we have Emperor and EMPA-REG for empagliflozin. And we've specifically looked at these 2 points, cardiovascular death and all-cause mortality. And you'll be surprised to know that the drug which has done best is actually canagliflozin. It has shown all-cause mortality benefit and it has shown cardiovascular death benefit. The second drug, which just touches 1, the confidence interval upper bound touches 1, that's dapagliflozin. And the worst of the lot is empagliflozin because it's being pulled down by the EMPA-REG, which essentially highlights again the point that you've made, sir, that it will entirely depend on the population that we are using the drug for. And I personally believe that all of these benefits is driven by the heart failure benefit and the sudden cardiac death benefit and the arrhythmia related benefits. So the renal patients often have this associated heart failure as well and sudden cardiac death, which is probably being reflected. As far as atherosclerotic cardiovascular death benefit is concerned, I am not convinced that any of the SGLT2 inhibitors have any benefit in terms of lowering that bit of the mortality.
Absolutely, I think that's a very considered, well considered opinion. So, will anyone amongst the panelists have any comments on this issue? Dianidhi, yes.
Yeah, regarding Sujata's take on this glycemic benefit with a low EGFR with a SGLT2 inhibitor, and hopefully that will be taken care of by this sotagliflozin, which is a combined SGLT1 and 2 inhibitor. That has shown good glycemic benefit even in patients having low EGFR in the last soloist WHF as well as SCORE trial in fact.
Right. Okay.
Possibly because acting on the
intestine, SGLT1,
small intestine in the SGLT1.
Right. So, Dr. Sambit Das, Dr. Sunil Kota, who else? Dr. Arundhati, any comments?
I think, sir, hello.
Yes, yes.
I think what Sujay sir has told is perfectly correct, because we cannot compare the three RCTs head to head, and though we have some CV benefits in EMPA that was not reflected in EMPA. So it's basically the study population which is studied, the result will come accordingly. So maybe the meta-analysis what he has done is going to answer everything.
That may be too much to expect that it'll answer everything, but
and in fact,
it'll open another bag of worms. Yeah. Right. Yeah. Sunil, did you have something to say?
No, sir.
Yeah. So I think all the panelists did a wonderful job, and I enjoyed the session very much. I hope all of you listening and participating did find it useful as well. And thanks to the organizers, the Micro DTF team. It's back to the organizers if they have something more to add, or maybe a concluding. Yeah, thank you.
So thanks to all the panelists, sir. It was really wonderful juggernaut of knowledge and this is flow. And really, sir, we are blessed to get all the best speakers in one forum. So this is the time to give a vote of thanks. So now I will request Mr. Shanbag Nagaraj, who is going to deliver the vote of thanks on behalf of Micro DTF. Over to Nagaraj.
Thanks, Sarangi. Good evening to everyone, and this is Nagaraj working as an AVP for Microlabs DTF business unit. On behalf of our company Microlabs and our entire DTF1 team, I would like to extend a very hearty vote of thanks to our honorable coach director, none other than Professor Dr. Shubhankar Chowdhury, for designing the format and preparing the scientific content of this ADF 2020 Academics in Diabetes Forum. Professor Dr. Shubhankar has been a great instrumental for us to roll out these scientific initiatives and disseminate the knowledge of diabetes and the recent updates through the leading KOLs to all the healthcare professionals across the country. I must mention our deep sense of appreciation to all our speakers for their dedicated preparations on their assigned topics with intense and most updated relevant details for their excellent presentation to make it more impactful with the key take-home messages. Thank you, Dr. Sujay Ghosh and Dr. Sambit Das and Dr. Sunil Kota, Dr. Dayanidhi Meher, Dr. Rana Bhattacharji, Dr. Arundhati Dasgupta, and Dr. Nilakshi Deka. Further, we are grateful to our doctors who have attended this ADF meeting on a weekend, that too on Sunday evening with us. I'm sure certainly this meeting would have refreshed and brought new updates in the field of diabetes, which will be useful for their clinical practices. I also wish to express my deep gratitude to our chairman and managing director, Dr. Dilip Surana and Mr. Srinath, for being our instrumental for their consistent guidance and support and motivation to conduct these kind of scientific meetings. We would like to thank Mr. Sharangi and who's been great support to organize this program, and also I would like to thank Rajarishi, Satya, and Victor Das, Dipanchan, and our entire senior managers from across the country for their guidance and direction to their team to execute the plan successfully. I also would like to take this opportunity to thank my marketing head, Mr. Gokul, and his team, Mr. Manas and Shubhashri and Charan, for their brilliant efforts for the back-end work to make this program a great success. This would have not been possible without our dear task force team members who are there in the field, who have toiled for many days, and appreciate their flawless execution with the passion and determination to make the event great success. Finally, I would like to thank our digital partner RX Events for their excellent service and an uninterrupted digital platform to execute this ADF virtual meeting today. Once again, sir, I want to state that we are most grateful and honored and privileged to our course directors to have with us in this evening, as well as the speakers and all the doctors on this stage. We thank you for being with us in this evening. It's been a great pleasure. Thank you so much, sir.
Thank you. Very
Thank
good
you,
night.
sir, and good night, sir.
Thank you, sir.
Thank you.
Hello. Hello. Subhashri sir. Hello.
Hello.
Meeting end
Yeah,
कर दूं मैं?
Darshan. Yeah, we can end up the session.
Okay, तो मैं end कर देता हूँ.
हाँ. And please share the entire video.
Okay, okay.
Okay. Yeah. Thank you.
Okay, okay. Hello. Mukul RX Events.
हेलो.
हाँ मुकुल जी मीटिंग एंड कर दीजिए.
जी 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 सर.
ओके.
ओके सर. ये वो